Ready? You ready? So welcome to Symptom Management and End of Life Care. I'm Chris Hansen. This is Jen Fork, who you know. We're going to be giving the talk on end of life care, very brief.
Where do you work?
I am palliative care as well,
But I mean,
only outpatient.
Outpatient.
Yeah. So, where Jen is the
And you do
inpatient
both,
queen.
right?
Yeah, I'm always out in the field. So the learning objectives for today were to distinguish and discuss end-of-life symptom management, primarily focusing on 3 different symptoms: respiratory distress, delirium, and pain, and recognizing the pharmacologic and non-pharmacologic interventions in the management of symptoms at end of life. Palliative care and hospice care, we thought we would take one quick second to distinguish between the two, although I'm sure you're very aware of the difference. So all hospice care is palliative, but not all palliative care is hospice. So the focus of palliative care primarily is on aggressive symptom management for uncontrolled symptoms that patients might be experiencing at any time in the disease process, and also focusing on goals of care discussions. So when we're asking, primarily our open for goals of care are, what is your understanding of your illness? What do you understand is going on? Because we often know that what we think patients know and sometimes what they do might be 2 very different things. Ask them again what it is that they are hoping for. What are they hoping for us to be able to do? And what is the most important to them? And tailoring their goals of care, all of their plan of care around their symptoms and addressing those needs. We're going to include managing pain, managing restlessness and anxiety, promoting comfort, and we'll talk about these more specifically as we get in a little bit further.
Will you be talking about the opioid addiction at all? If not, I'm just wondering.
No, it's a great question. So Jen's going to be doing the pain portion. And so in end-of-life care, it's a little bit less of an issue, right? Because we don't have them long enough to have that develop into an issue. But what I would say is, Diana, we're hoping to do more of these types of lectures. If that's something specific that you would be interested in, because I have a feeling a lot of people would be, to be honest, that would be a perfect grand rounds, and we'd all be happy to do that.
That's a good idea.
Yeah.
That's a great idea.
Right. So we always, in all fields of nursing and medicine, we always start with our physical assessment and our patient history. So we use that in managing the symptoms of end-of-life care just as much as we do in the beginning of their disease process. And we always are going to use those as guides to reevaluate the effectiveness of our interventions and change our plan of care. So what causes specific symptoms at end of life? Obviously, as we are having multiple system breakdown as patients are progressing in their disease, we have metabolic changes. They cause restlessness, altered level of consciousness, delirium, and we're going to talk about those, as well as some respiratory and metabolic changes. So air hunger, symptoms of ineffective breathing, and changes in respiratory patterns. Also, as patients get weaker and have generalized musculoskeletal decline, we'll find that swallowing dysphagia, altered cough reflex becomes more common as well. So and continuing, we are going to look at diseases, medications, and changes.
Woohoo!
Yeah, how are you?
Sorry to interrupt.
No.
Grab one of those handouts. Here's the thing. The more the better.
I'm going to actually skip that because I want to get right to it, and I fold all that in. The first symptom that we'll talk about is delirium and agitation, because on the needs assessment that we distributed out to the nursing staff, they specifically identified 3 areas that they felt they needed more education on when it came to end-of-life care in patients, and delirium and agitation was one of them. And I always like to start because I think delirium is one of those diagnoses that often is confused. There's dementia, there's delirium, there's acute confusion. And
The 3 Ds, I learned. Delirium, depression, dementia.
Exactly. And they often can coexist, but trying to tease out what might be the most predominant is the most important. So I like to include the definition of delirium. So it's a disturbance of attention, cognition, and consciousness.
Ooh.
So we'll see that they have difficulty focusing suddenly, different in their thought process, and oftentimes a change in their level of consciousness, because we can have two different types of delirium. We can have a hyperactive delirium where people are acutely agitated. I think that's what we most commonly think of when we think of delirium. Or we can have a hypoactive delirium where patients are actually somnolent and we think they're just somnolent when it can be a form of delirium for them. Up to 83% of all patients will develop delirium, some form of delirium in their end of life. Sometimes that also accompanies with hallucinations and delusions, and that's often when we get the call. Causes. In order to treat delirium well, we're better off trying to find out the cause of the delirium, rather than always just going right to medications, which I think we're always comfortable with because it's such an acute and distressing event. We usually try to jump toward medications. We want to really also look at what is causing the delirium in the patient, because if we can reverse that, then we might not have to be over-medicating the patient. So some causes are, and the most frequent causes are metabolic, especially at end of life. So they could be hypoglycemic, they could have an infection, they could be dehydrated, hypoxic, pain is very common, sleep disturbance, altered sleep-wake cycles, urinary retention, and constipation. These are some of the most common causes of a metabolic delirium. All of them, if we find out what they are fairly easy to treat. We can adjust the blood glucose, we can treat infections with antibiotics, we can give fluids for dehydration, O2 for hypoxia, manage their pain better. Sleep, one of the latest studies in Cochrane Review, which I thought was really interesting because I think we use it often in palliative care, is one of the best sleep resetters, in addition to sleep hygiene for our patients, even at end of life, is the addition of melatonin. And melatonin dosing a little higher than what you might be used to. So we might be talking 5 to 10 milligrams instead of a 2 to 3 milligram dosing. But doesn't cause the hangover in the morning, doesn't cause that grogginess in the morning, which adds to worsening delirium, but helps to alter your sleep-wake cycle in a very more predictable pattern. So we use that.
Are there any down side effects?
For melatonin?
Yeah.
Not from a drug-melatonin interaction. It's just that some patients, if you start at a higher dose, will find that early morning waking can be a little more challenging. But other than that,
But
nothing.
it doesn't change. I don't remember
Right.
what I remember.
Hormonally?
Or
No.
sleep-wake patterns or...
Well, we use it to try and adjust that.
Mhm.
So melatonin you're only going to be giving at night. So you want it to be precipitating sleep. So if you can dose it between like 9 and 10 o'clock at night, knowing that it's going to take about an hour to an hour and a half for that to be different. And melatonin is more cumulative if you keep administering it, whereas Ambien or Rosarum or anything else that we're using that way, very quick. Melatonin, while it can help in the immediate end, is also one of those much better things that we give long-standing because it helps establish that sleep-wake cycle.
You say it's cumulative, so it doesn't cause drowsiness during the daytime?
Does not have that long-acting daytime, not like a Benadryl would or what have you.
They also, for home use, have the dissolvable stuff now
Mm-hmm.
that works a whole lot faster.
Mm-hmm.
Best friend of night shift nurses.
Yeah.
And my understanding is they also have a crystallized that you can mix it into your 8 ounces of water
I think
too.
they had gummies. I think
Mhm.
my daughter was using gummies at one point in time
Yeah.
because it's not age limited either.
Interesting.
No, it is a very safe, usable thing. And then, so those are some of the, if they're urinary retention, obviously with put a Foley in them, sometimes that makes all the difference in the world. And if they're constipated, obviously, time to literally dig in, physically and otherwise, right? Then there's pharmacologic causes of delirium. Medications, we all know that medications can cause delirium. Drug-drug interaction, so oftentimes at end of life we'll have patients on opiates, we may have them on benzos together with their opiates, we may even have them on antipsychotics with their opiates and their benzos. So if we've ruled out all the metabolic causes, step 2 is always, let's look at the drugs. And we're better off in delirium trying to pull away medications to see if we can see a change in that. Sometimes the delirium is caused by brain tumors, anything that's neurologic in etiology. And then for us, of course, a lot of our patients will have terminal delirium, which is at the very end stages of life, and that's mostly related to metabolic changes within the body as well. So how do we treat delirium in addition to trying to hit the causes of the delirium and kind of circumvent that from continuing? The first thing that's easy enough for us as nurses, and part of our great nurse training, is how do we be a nurse, right? So creating a therapeutic environment. Hi, how are you? Calm. I'm sorry there's no lunch. So we want a calm room as much as possible, and we're kind of lucky here at Einstein because all the rooms are private, and so we can try and make that a little more quiet. We want consistency if possible of the nursing staff, the care staff, because that familiarity, if we can, becomes important. Reassurance. The other thing that we always forget, myself included, is when they come into the hospital, we sometimes put their glasses in the drawer, their hearing aids, you know, if they're not in, we might not even think about it. And one of the things that also causes worsening of confusion and harder redirection is if they can't see us and they can't hear us, that really exacerbates how delirium is exhibited. So remembering quiet, calm, less stimulation, anything that's an assistive device they're used to using, make sure they have access to it and we're doing it.
I actually, just to dovetail on that, Chris, I actually had a patient a couple weeks ago in the ICU who was deaf and blind, and so we actually didn't know she was agitated, and we didn't know if her agitation was end of life because she did have a lot of chronic illnesses that, you know, were leading up to a hospice conversation, but we didn't know if it was end of life terminal delirium or if it was that she just couldn't hear and see us, and it was heartbreaking. It was, and thank God her niece told us that, you know, because she was also on the ventilator. So yeah, so it was like, oh,
What a prisoner.
Yes, yes. So it ended up that she was having some end of life delirium, and we were able to talk really loud at one point, get her hearing aids that she could hear us a little bit, but she was demented also. So she had.
Oh,
this,
wow.
Oh my goodness, you have like the perfect storm.
It was a shame, yeah. So it was, it was really tough. So I do, you know, I'm gonna second that what Chris said about getting glasses and hearing aids, because of course that can be a little bit more helpful if it's possible. But of course, her situation.
And we don't always think about that
Right.
because they're acutely delirious, and that's the last thing
Right.
we're thinking about, right? Oh my goodness. So then we go into, if we've done everything, we've tried to reverse the cause of the delirium. We have pulled back medications that we think are causing the delirium. We've put in our therapeutic environment, we're left with pharmacotherapy. So what are the most common medications used for delirium? The first one that we use, and I'm going to preface this by saying what I'm going to say to you is what we do as standard of practice. However, a new study published this year in JAMA is going to challenge what I'm telling you, but we're waiting to see part 2 of that. So what we do in practice, and what has always been the mainstay of practice for us, is the use of haloperidol, so Haldol. Anywhere from 0.5 milligram, usually to 1 milligram. All of us have had that delirious patient that we need more than 1 milligram for. But that's our typical mainstay antipsychotic that we use. In JAMA, the research was showing that, in fact, antipsychotics can make delirium worse. So the study was double-blinded. One arm was haloperidol with access to Ativan. The other was, so there's 3 arms. The other was Haldol and midazolam. And then the third arm was Haldol alone. So what they found was, and this is probably going to sound common sense, the group that had Haldol and midazolam had the best results. Well, that's kind of duh, right? That would be an understatement. However, it brought into question, is what we do in practice, in fact, truly what we should be doing in practice? So now that study is going to be try to be replicated and see if in fact we're finding that antipsychotics are maybe not the mainstay of delirium treatment. So that's still to be determined, but in the interest of full disclosure, I wanted to let you know where that was. We also can use atypical antipsychotics. So we have Zyprexa, we have Risperdal, we have Seroquel. There's some patients that I find Seroquel works beautifully for because we're able to dose it a little more frequently and hit them at their points of agitation. And we can start at very, very low doses and work up with that. The only difference with haloperidol and your atypical antipsychotics is that the atypicals are going to prolong your QT interval. Now, we're talking about end-of-life care patients today. So for us, not such an issue, right? But talking about delirium more broadly, we'd have to be mindful of that. If they're on amiodarone, or if they're on Levaquin, if they're on any of those other medications, then we really would have to be mindful of that. The other medication that we use, and we also know now, is a big Happy the Clown no-no in a good portion of the cases, is we always throw in our benzodiazepines here, right? So we're giving them, when they're delirious, we're giving them their Haldol or atypical, and then we're giving them Ativan, or Valium, or Klonopin, or Xanax, what have you, whatever benzo of our choice. And this we do know for sure. A significant subset of delirium patients will get acutely worse when we add a benzo. So start with your antipsychotics and hold the benzo as long as you can, because you might find an escalation with that. And then we talked about these other things for the delirium, sensory aids, decreasing stimulation. One of the other things that I saw in a study, and I'm starting to use it in my nursing home delirium patients, and it's working kind of nicely for them, unless they have an allergy. But I don't know if you can see the picture, and Sarah didn't even know I was going to talk about it, but lavender oil, this just pure lavender oil, and rub it in a little bit on their wrists or any of their pulse points, or you can, if they're not clawing at their eyes, you can put it on the back of their hands just so they can smell that. Lavender oil, the smell of lavender tends to be very relaxing, and there is a connection with the olfactory nocioreceptors and the brain for trying to interrupt that delirium escalation. So that can be like an easy nursing intervention, or something the family can even do to be able to help with that. We talked about sleep, we talked about avoiding the use of restraints if possible. I think we've all seen that delirious patient that as soon as we restrain them, it's so much worse. Sometimes early mobilization helps get them moving a little bit if it's within safety parameters, obviously, just to work off some of that angst. Any questions on delirium? Okay, so respiratory distress is the thing you probably see the most commonly at end of life, people with shortness of breath. The respiratory center, so dyspnea is the sensation of breathlessness. And I always say this because I think sometimes we as nurses forget that not all people who have dyspnea are hypoxic. So how we treat them sometimes is going to be a little different too. So you can feel very acutely short of breath and be pulse oxing at 95, 96 and not having any hypoxia whatsoever. What is respiratory distress? The respiratory center in our brain, we have three main respiratory centers. One is our peripheral nocioreceptors. So on our cheeks, we actually have nocioreceptors that allow our brain to recognize increased airflow. So oftentimes, if you've ever seen a patient who has chronic COPD, we say get a little tabletop fan and have it blowing right on your cheeks. That's why. It actually tricks the brain into expecting that they are getting a lot more airflow. Even if they're not, these nocioreceptors are sending that message. Then we have the respiratory center in the brain, which is the medulla and the pons right there. And they talk directly. And then we have nocioreceptors in our anterior chest wall, which makes sense. So we have all those nerve endings in our lungs. So any interruption in that flow, anything that's causing a difference or a problem there is going to be causing shortness of breath for patients. And accompanying shortness of breath is probably always the worst thing for us to watch as clinicians, is the anxiety, the fear, the panic that comes along with patients who are having respiratory distress. So how do we treat that acute respiratory distress? Again, we circle back to our assessment and our history and physical and trying to figure out what the cause is. So if we have a patient with COPD, we're going to revert to our mainstays: oxygen, nebulizers, so bronchodilators, anticholinergics, whatever we happen to be using. Sometimes antibiotics, it's infection. Sometimes prednisone, steroids, and then we'll cause our delirium, and then we can treat that. But no, those. So if you have a COPD patient who's obviously acutely having respiratory distress, we're using what we know works for them. If it's somebody with CHF, then we're thinking it's high volume overload. So we're going to be adjusting diuretics. We might be doing thoracentesis if we need to, paracentesis if we need to. If it's a chest wall tumor, if it's lung cancer, if it's something compressing the trachea, lymphadenopathy, what have you, if we can do palliative radiation, a short course of 2 or 3 days of intense radiation, sometimes we see enough tumor shrinkage just to obviate that acute respiratory distress. A lot of times in end-of-life care, we'll have patients with anemia, and as soon as they drop to 6, they're working. Sometimes 5, sometimes they're a little used to being anemic, and 5 is where it happens for them. And administering blood for them, especially if they're not actively dying, if we know we might have months, that's a quality of life issue, and it can really make such a difference in their dyspnea. So those are just some, treat the cause. If oxygen is needed, meaning if they're hypoxic, we're going to give oxygen. We can do nasal cannula, we can do BiPAP, we can do high flow O2, whatever we need to do in order to maintain their oximetry for them and get them comfortable. Very interesting study though, for patients who are short of breath but not hypoxic, they put them head to head in a clinical trial. 2 liters of O2 versus room air. No one knew what they were getting. Okay, room air through the nasal cannula or O2. If they were not hypoxic, they got the exact same relief from O2 as they do from room air. So again, it brings us back to those nocioreceptors, right? It's that sensation of getting more air. So that always gives me chills because we throw everybody on O2, right? But that means that moving more air, feeling more air really helps them. End of life, we have patients who, with their shortness of breath, develop a lot of secretions. Comes back to where we were talking about sometimes dysphagia, the weakness, their swallow reflex not the same. So how do we treat that increase in secretions so that we're not having a lot more acute respiratory distress? So atropine drops under the tongue work very quickly. Levsin works very quickly. And we sometimes, if we know we have a longer period of time, once we've done the atropine or the Levsin, we'll put them on a scopolamine patch. Just know that the patch is going to take 12 hours to work. So that won't be your slap it on and everything will be good right off the bat. But that's a good long-term therapy.
Dr. Johnson also started using Rubenol.
Rubenol,
Yeah,
yep.
also for the inpatient.
Any anticholinergic really will work for that. It dries everything up. And then expect that they're going to have urinary retention and constipation because we're drying everything up. So we'll have to treat those things. But it really can make a very big difference. Rubenol's nice and dirt cheap too.
Yeah.
So it's a very inexpensive use. And then we have nonpharmacologic therapies, of course. Again, like we talked about, the fan, sitting upright, tripod position, pursed lip breathing. Lavender oil, again, was brought up. But I think positionally, COPD patients in particular really do well. If we do all of that, and we still have patients who have respiratory distress or something that they find distressing. We might not find it to be overtly dyspneic, but they are feeling dyspneic. The mainstay of therapy for shortness of breath is opioids. And we've run, now these trials we have done almost every 5 years in hospice and palliative medicine, and always the results are the same. We always, I think, are looking for the next best thing because patients and families hear the word opioid and they panic, or they hear the word morphine at end of life and they think we're trying to facilitate a quicker death. So I think as a specialty for us, we always want to try and find something that's not an opioid that's going to help them. But every single time we do this, we always come back to opioids are the best. Not only do they change the receptors, interrupt the receptors from the lung to the brain to send a message that the shortness of breath is not as acute, it also vasodilates and it also bronchodilates. So they work well. We always use morphine as our gold standard. However, if somebody is allergic to morphine, any opioid, they're starting to run those head to head. No one opioid shows significant increase in efficacy than any other right now. You just want something that's quick acting. So if we're putting on a transdermal fentanyl patch, that's going to take 12 hours. So we want something that we can use quick acting. Most of the time you'll find us using something in a liquid form because even swallowing a pill for dyspneic patients can be difficult. If they have dysphagia, it's worse. So we'll use the Roxanol. We'll use anywhere from 5 to 10 milligrams every hour. We can go up to 20 milligrams an hour. We go with whatever we need to do. We used to think there was something called respiratory dose. This is when you've been in NP too long or in end-of-life care too long. There is truly no such thing as respiratory dose. We just said that so we didn't scare the crap out of everybody else when we said we need morphine, and they're like, 5 milligrams of morphine. I'm like, oh, that's just respiratory dose, There's really no such thing as that. But they really do, they are the magic bullet for relieving dyspnea. Second line agent would be your benzodiazepines. And the reason for that is, along with feeling so short of breath, is that anxiety, panic, and fear. So we're treating them concurrently. What I find a lot in practice, I don't know how about you, Jen, but I feel like oftentimes in the hospital as well as long-term care, physicians will prescribe the benzo first instead of the opiate.
I find that, but I also have found recently that when it's not end of life, they are very nervous to prescribe benzos at all because they feel it is going to decrease their respiratory drive. And I actually had a conversation with one of the intensivists, who will remain nameless, but he does not like to prescribe Ativan or any sort of benzo for his COPDers or anyone who's in respiratory distress because he is nervous it will decrease respiratory drive to the point where they will need BiPAP to intubation. And if we haven't had that goal of care conversation yet, he's very nervous to pursue any sort of benzo treatment.
And it's interesting because, which I'm so glad you brought it up. So it's interesting that when they do the studies on this, the number of people who experience respiratory depression to any degree, so not just 10% or not, we're not even talking apnea, we're talking just respiratory depression. It is almost less than 7%. That includes opiates and benzos. So it's rare.
Right.
We think it's not rare. Now again, if we're hitting them with midazolam, that's a whole different story.
Right.
But if you're appropriately dosing, you're just not seeing it.
Right.
You're not seeing it.
And that's the thing. I mean, you could always start with 0.5 milligrams for someone who's end-stage COPD, but we're not talking end of life, in oral form even, and it's not going to hit them as hard as even 1 milligram of IV or what have you. And it's just, that is the very conservative way of just prescribing something for them so they can get some sort of relief from that anxiety, from the shortness of breath.
And they've done studies now, so you might be asked to try it once in a while to nebulize everything.
Yes.
Let's nebulize our opiate. Let's nebulize Lasix. They've tried to do that and see if that works for patients who are diuretic resistant, but they're in CHF and having respiratory compromise. They've even nebulized anesthetics, so nebulized lidocaine for cough, for cough, shortness of breath, that whole sensation. And while we all were hoping that might make a difference, the clinical data just doesn't bear through. But so in this case, the old standbys really are still the answer. And any questions for those two?
Can I ask about the glycopyrrolate, the Robenol versus the atropine? Has there been a swing towards that? And I see it in hospital too. And of course, in the olden days, we used atropine all the time. Is it newer and more
Well,
effective and shorter acting?
There's two reasons why you're seeing the swing. One is economics. The other is that there's an atropine shortage. So it's harder to get. So we
Do you
always,
know why?
no, it's a manufacturing problem. At least that's what we've
Yeah.
always been told. And ophthalmologists will always get first dibs on what atropine is available because this is off-label use for it. So it's just harder for us to get it, to be honest. Easier to get the Robenol and cheaper.
So moving on to pain management. So of course pain management is probably, from what I've heard from the nurses, is probably one of the scarier portions of, patient care, just because, regardless if you are on 3 West or if you're on the 4th floor, the nurses on 3 West seem to be a little bit more comfortable with, of course, giving them more frequent pain medications, but it can be scary because you're used to giving some of your patients pain medication and then you see the lethargy that comes along with it or what have you. And I've actually heard recently in the last couple of weeks that a lot of the nurses do have questions about how to kind of stagger the medications for their patients and even with end of life care. So we have the WHO pain ladder scale, which is, it is helpful because, and this to me more or less I think it benefits more if you're not end of life, because I feel like some of these rules go out the window when you're having any sort of symptoms at end of life care. However, the ladder does kind of tell us that, of course, you should start with any sort of non-opioid medication. So that would be Aleve, Tylenol, Motrin, any sort of thing like that. And of course, some of your adjuvants, which we'll get into in a minute. But when you're talking about end of life care, it is difficult to kind of draw that line of, okay, well, my mom never had any sort of opioids before for any sort of pain issue. So do we have to start her right on morphine? We've been asked that a few times, and of course, if a family member is very hesitant to start right on an opioid, then we will say, okay, well, there's lighter narcotics, or we can start on Aleve, or we can not do anything at all for right now. But just so it's better to get these things kind of in their system before there's any sort of crisis situation. So it is a discussion that we often have with family members who are nervous about, just like Chris said, about even prescribing 5 milligrams of morphine for their family members. And then as you move up the scale, of course, you can see that there's, for mild pain, that you would start, you could start a low dose opioid, and then moving along, you could start opioids for more moderate pain along with a long acting if needed for even severe pain. So, but again, I think that this kind of goes out the window for end of life care, because I feel like you need more persistent opioid management for pain when it comes to any symptoms that patients are having at end of life. So patients who require multiple doses of short-acting drugs may benefit from scheduled long-acting opioids. So of course that means if you're giving your oxycodone or morphine or whatever it is that you're giving for pain management every 4 hours, but they're asking for something at hour 3, then maybe it's worth taking a step back and saying, okay, well maybe we should ask the doctor, or of course you could always ask Dr. Johnson or myself, what about adding on OxyContin or MS-Contin to have a long-acting, or even a fentanyl patch, depending on what the patient's past history is with any sort of narcotics or opioids. And we find that when we do start those things, and of course fentanyl does take a little bit of time to get into your system, so that again takes a few hours, so you're not going to see the immediate results from the fentanyl patch. And same thing with MS-Contin and OxyContin. If you start that, usually I've had experience with not seeing the effects of it. Like of course, if you start at 9 a.m., you might start to see the effects of it by 9 p.m. I rarely see that. I usually see the next day the patient's feeling a little bit better. But when you do start the long-acting medications and add in the whatever it was they were having before, again whether it's Roxanol, morphine, or oxycodone, you see that sometimes they don't need it as often as they were having before, and of course that's the goal. But if they still do need it, then of course we can always reassess with the long-acting dosages and increase that as well for help. And of course if it's really not helping them, if they persist with their pain, then of course a PCA pump would be something that may be a benefit to them if they're conscious enough to understand how to use the PCA pump, of course. So the adjuvant therapy that I was discussing, or saying that we were going to discuss, is more or less medications that are non-opioid, or not even just medications, but it could be things that are non-pharmacologic as well. So it would be helpful if they're not responding to opioids, or if they or their family members are concerned about opioid use in general. So the anti-neuropathic medications such as antidepressants and anticonvulsants like gabapentin, Lyrica, things like that are helpful for kind of neuropathic pain and neuropathy pain. Then we have steroids, which can be very helpful for things like bone pain from bone mets if the patient has cancer. Same thing with biphosphonates. Ketamine we don't use very often here. I've actually only seen it used once in my time here at Einstein, and it was just used in the emergency room.
Penn's real big on ketamine.
And I don't even think it was used. Yeah, I don't even think it was used. I think it was used because the patient was like agitated. I don't think it was used because of like actual pain management.
We use ketamine for, not here,
Yeah.
but we'll use it for phantom limb. So if somebody's going to go in and have an amputation and we know they're going to have phantom limb, they can dose with ketamine 3 to 5 days prior in the hospital before amputation, and it actually rewires the brain to not be able to recognize the phantom limb as much. And the other thing,
Long
Jen,
term?
yeah,
Yeah.
good, some good, interesting studies for that. And the other thing that Jen mentioned, which is great, was the diabetic neuropathies. We used to throw opioids at that. We now know opioids do nothing for diabetic neuropathies. Those atypicals, it's your Lyrica, and the number one treatment for that is actually Cymbalta.
Or
Cymbalta works.
amitriptyline even. Yeah, so the antidepressants do work really well for neuropathy pain. And the neuropathy pain, just like Chris said, for diabetic neuropathy, as well as a lot of patients that we see, unfortunately, get neuropathy from chemotherapy. So any sort of chemotherapy agents cause neuropathy, whether it's in their fingers or in their toes. And I've had good results with Cymbalta for my patients who do have that type of neuropathy. And the non-pharmacologic things would be things like complementary therapies that are more or less the capsaicin creams, topicals, of course, lidoderm, which is pharmacologic, I know, but still I feel like capsaicin and Salonpas is another one that the patients can even get, over the counter that are more available to them. To help with any sort of pain. Music therapy, massage oils, just like Chris was talking about, the lavender oil and chamomile. And I've also heard of peppermint oil being very helpful for things like headaches. And that is something that we were actually working with I'm on the pain committee here at the hospital, and we were working into finding out about aromatherapy to see if we could get it started here at the hospital. Because I do feel like it's something that can be very beneficial, not even just having the oils, but if you just even had the little bags of lavender that you could leave by a patient's pillow, have it pinned to their pillow so that they can smell that, and help them calm and relax during their time here at the hospital if they are agitated or having the pain. So I think that's something that we could still try to look into to see if we can get more, funding to have some of us, qualified to do for our patients. The other thing is, of course, things like guided imagery and, the biofeedback type of remedies, which I do more or less talk to my patients about if they are not end of life, when they're not terminal, if it's more of a, this is switching gears a little bit, but if they are more chronic pain and they've been on a slew of different medications that are not helpful for them, sometimes things like guided imagery and biofeedback can be a little bit helpful to them to at least try to steer them away from thinking about their pain medication for a short period of time until they're due for their next dosage and what have you. But it could also be helpful at end of life as well, because it can kind of help relax and calm the patient, which a lot of times anxiety does precipitate pain. So if we can kind of help manage a patient's anxiety and it could also help with their pain management as well.
Can I ask you a question?
Yes.
Actually, two questions.
Absolutely.
I have to read this down first. So the first question is biofeedback. Their machines are expensive. Do you get them a machine? Do you recommend a particular one? Or are you talking about the sensors with the?
No, it's more or less, even here, the biofeedback, I think more or less, and it kind of.
Not in the traditional sense, because you're right,
Yeah.
insurance doesn't cover biofeedback anymore. They used to, they don't cover it anymore.
So what do you use?
So we've just kind of mentioned to them, like, as an outpatient to seek some sort of like psychiatrist type of, psychiatry type of consult, if you will. Dr. Johnson and I were recently talking about this because guided imagery is easy enough. Like we could do that here at the hospital on the TVs and things like that, of course.
That's my next question.
Yeah,
Or do you give them tapes? What, is there a
There-
particular person that you think does a good job?
Well, Dr. Trachtenberg does a fantastic job.
Does he have a tape available?
I don't know if he has a tape, to be honest with you. I'm not sure, but I've actually sat in with him trying to explain how he would do it for a patient, but we also have the different channels and things like that.
What channels are they?
There are, I don't know the
Or you
numbers
can tell me later,
specifically.
because I only found the relaxation music, but not.
Yes, because to be honest with you, 3 West, the nurses are really good about just hooking it up, so I know it's there, but I don't know specifically
How to
which
get there,
Yeah. So it's terrible of me, but yes, the 3W nurses really do know how to, and of course you
I
have,
can ask them.
yeah, and of course they
I've
even-
tried to find it myself to use for a patient.
They've
and-
even just Googled because it is hooked up to the internet. So they just Googled like, you know, different types of music even, or music along with like the scenery or what have you, in order to kind of help relax. And this is even for patients who have had delirium, to kind of try to calm them down. So yeah, because we have the access to the Wi-Fi through the TV system, that's what they've used.
And outpatient, if you go on to the chronic pain forums, so again, not end of life care per se, but if you go onto the chronic pain forums, there's apps that patients can use on their phone, that they can have access to whenever they're and wherever they are. They plug their headphones in, or they're in the car, roll the windows up, and it'll really do guided imagery with them, a little sensation of cognitive behavioral therapy, and mild biofeedback.
Do you find any particular
It's such.
recommendation? Do people say, oh, this one really works good for me?
There was one on mine.
Because to me, it's like
On
sometimes the tone of voice.
Oh yeah,
and-
Absolutely.
And you can find what works for you. 'Cause
Exactly.
it is a type of meditation, even really. So there's even meditation apps, and I've used one in the past, and I can't remember the name of it. But it all depends on what your specific, you know, not necessarily your needs are, but what your, you know.
Keep talking. I got the one on that.
Oh, you did?
For
Okay.
patients.
But yeah, so it just depends on what your specific likes and dislikes are in regards to the voice and the type of imagery they're providing and things like that.
I find that, and now I'm forgetting his Harold,
Herbert Benson.
okay.
Yeah.
I have one of his tapes,
Mhm.
and it, you know, and like, yeah, of course I have a bunch of tapes,
Right.
but it's like, that's like the best one.
Yeah.
For
In
me,
your opinion, yeah,
because
sure.
I like his voice.
Sure.
It doesn't irritate me. It's, you know,
Right,
it's a wake up
Sure,
meditation,
nothing
and a
else.
sleep meditation, and
Absolutely.
anyway. But they're hard to. But I always am reluctant to
Yes.
buy something that I've never.
Right.
I don't know how good or bad it is.
The one app that helps some of my patients, it's called Calm, CALM. And it's all different meditations, and you can kind of tailor make it to what you're looking for that day. Is this for anxiety? Is this for depression? Is this for pain?
That's nice. That's great to know. So of course, another big part of pain management is evaluating the pain. So you want to continue to reassess after your intervention. So of course, you know, you ask the patient how much pain they're in, and then of course you have to remember to document your reassessment of that pain, of the pain medication. So of course you have your numeric pain scale from 1 to 10, and then you have the FACES scale, of course, if someone is unable to let you know how much pain they're in. And the other thing is again, you want to do skin checks, assess their oral cavity for areas of irritation, breakdown, potential infection, and monitor changes in respiratory effort, level of fatigue, and level of restlessness. So basically, you just want to make sure, you know, reposition the patient, elevate their extremities if you find that that's helpful for them, and, you know, again, even, you know, just evaluating their pain and making sure that what you did, whatever intervention you gave, is being helpful for them. Because of course, if you see that, you know, the night nurse before you or what have you has documented that their pain level is still an 8 after their oxycodone morphine, then obviously we need to reassess the situation if it's not working for them. And so I didn't know if anybody had any experiences, or of course I have plenty, but if there's any patient experiences that you've had recently or in the past that, you know, you had trouble with end of life, you know, whether it's pain or delirium or respiratory distress, or you feel that you you know, could use more help, or, you know, any sort of feedback you could give us, you know, might be helpful so that we can continue to educate the nurses. No one really can give any sort of prognosis, in my opinion. You can say, okay, you might have, you know, 3 months or what have you, but people ask me all the time, and I don't give them a time frame. I say, first of all, it's not my decision, you know, and second of all, I've been wrong on so many occasions of what I've thought, and someone had been extubated in the ICU and lived for a week past what I thought that they would have lived. So I really have no idea, and it's really difficult to put a time frame on anything because, you know, anything could happen between, you know, they could throw a blood clot and be dead in 2 seconds, you know, so you never know with prognosis, and it's just, I really, you know, the percentage just sometimes gets me.